Welcome you again to our virtual spine education. Today we have a special session. It will be one of our colleagues from radiology will speak about some cases in cervical spine. So this moderator will be myself and Dr. Bako and Dr. Saeed, if you would like to introduce Dr. Botchu.
Thank you very much. Welcome everybody. And Rajesh, thank you very much for joining us and agreeing to do this session. Dr. Botchu has an exciting journey to the radiology. He is consultant radiologist in Royal Orthopedic Hospital, Birmingham, but his journey has been very exciting and to the benefit of orthopedic community because he was trained orthopedic surgeon in India. He did MS orthopedics in India. Then he was orthopedic registrar in UK and trained in Oxford and Leicester. Then he switched specialty and jumped the ship to greener pastures and has been very active in radiology. He has published more than 50 peer-reviewed journals. 12 of his book chapters and another 20 papers are in pipeline. And he has been instrumental in creation of musculoskeletal radiology for you.co.uk. And this is a very, very significant learning resource for both orthopedic and radiology trainees. And I would recommend everybody to log on to that. And without any further ado, I will give mic to Dr. Botchu. Welcome, Rajesh.
Yeah, thanks a lot for inviting. Thanks a lot, everyone, for joining today. So thanks a lot, everyone, for joining today. So my name is Rajesh Botchu. It's very kind of Saeed and Abdul and Dr. Bako and all the other faculty from Hamad for inviting me to give a talk. What I thought was the best way of doing this is to show some cases, and then we are going to discuss what are the positive findings and what are the things to look out for in these cases. So the way we are going to do it is we'll try to make it slightly interactive. One second, if I can show. Why is it not showing the slideshow?
Yeah, it's not showing the slideshow.
Okay. Okay. So I will minimize. I don't know why it's not showing the slideshow. Okay. So as Dr. Saeed has said, there is a free website and resource called
Rajesh, if you try to go to from current slide, it might work now.
From start, it's not. It's something to do with Zoom, is it?
Usually it works.
I think from your side, if you can reshare it again, you just disable it and reshare it. We'll see.
Stop share. Okay. And then share screen again. And yeah. Oh. Yeah, there we go.
Good,
yeah.
Thanks.
Sorry for the technical hiccup. So before we go on to today we are going to talk about the radiology aspects and I'll give you some, in each and every case, there will be some certain key pearls or certain findings that one needs to look out for. And Abdul has kindly agreed to have a go at these cases, and I appreciate this thing. So before we go on to that, I want to let you know about two seminal papers. There's a paper that we wrote in BJJ way back in 2015 about the various techniques of spine imaging. And I suggest you read about this and that. And then nowadays, more and more people are using standing MRI or upright MRI. And we wrote an article in European Spine Journal on this. So I suggest, as far as radiology is concerned, if you want to keep yourself up to date with the latest techniques, these are one of the two seminal papers that we wrote in 2015 and 2017. So without further delay, so the first patient is a 60-year-old who presented with neck pain. And these are his radiographs. So what do you think, Abdul?
So this is a lateral X-ray of the cervical spine. I can see that there is a multi-level degenerative changes on the facet and the facet posteriorly and decreased disc space in multi-levels. I think there is all over anteriorly marginal osteophytes and
yeah. So we agree that there is gross degenerative change and all, or there is narrowing of the disc spaces and there is some osteopenia and all. Is there anything else that catches your eye?
So I think there is marginal osteophytes anteriorly. And this is affecting the disc space.
Yeah.
I think this is ankylosing spondylitis. Case of ankylosing.
So there is no ankylosis as it is. I agree that there is loss of some joint space, but we can't see any flowing bone or like a bamboo spine. So whenever you look at spine, there are two things that are very important. First thing is alignment. You have to ensure you look at the alignment. And the way you look at the alignment is you draw a line along the anterior spinal line, anterior vertebral body spinal line, posterior vertebral body spinal line, and the spinolaminar line. So as far as this is concerned, this is C2. And you see the alignment from C2 is fine. But what about C1? If you look at these...
there's increase in ADA interval.
Yeah. So, and that is the posterior arch. So normally spinolaminar line. So if you look at what I'm talking about,
sometimes.
So if you see at the top end, and what we can see here, so that is the anterior arch of C1, and that's the posterior arch of C1. So you can see that there is
C1, C2 instability.
Yeah, C1, C2 gross subluxation because there is increased predental space. So whenever you see increased predental space and there is marked subluxation, you have to think about what condition causes that.
Like inflammatory, like rheumatoid.
Absolutely. So this is a patient with rheumatoid arthropathy, rheumatoid arthritis. And that's the reason the bones are quite osteopenic. There is loss of joint space, I agree. I can't see any discrete, I can see tiny osteophytes. But normally if it is pure OA, osteoarthritis, then you wouldn't expect so much osteopenia. You would expect more sclerosis, more osteophytes. Yeah. So this is a patient with rheumatoid arthritis, and it's important to identify that. If you have a suggestion, that somebody has got atlantoaxial subluxation and the normal standard lateral radiograph is normal, you can do flexion extension views.
Yes.
So that is one way. And the second important thing is to see the soft tissue in front of the vertebral bodies. In this case, the vertebral body soft tissue is normal. So we know that it's a chronic process. Yeah.
Yes.
So this is the case of atlantoaxial subluxation in a patient with a background of rheumatoid arthritis. And it's important because for pre-op, if somebody has a hip replacement or knee replacement, the anesthetist wants to know this. Okay, good, well done. So whenever you look at the alignment, as I said, you look at the spinolaminar line. In a spine, normally in the cervical spine, you have a normal cervical lordosis. Yeah.
Yes. Yeah.
If the lordosis is lost, then you can have either scoliosis, you can have hyperlordosis or kyphosis. So whenever you look at a cervical spine, in order to identify the normal alignment, you have to draw a line from the posterior inferior part of C2 to C7, and no part of C3 and C6 should cross the line. What I mean is this. So if you see, this is diagrammatic representation, that is the posterior inferior part of C2, and this is the posterior inferior part of C7. So if I draw a line, all C3 to C6 vertebral body is anterior to it. This is normal. When you compare that with this, you can see that there is straightening or loss of cervical lordosis. And what about this one? There is exaggerated cervical lordosis. When you compare that with the first one, there is exaggerated cervical lordosis. And in the last one, you can see when I draw the line, in fact, there is kyphosis. So it's important to identify the normal alignment. Okay?
Absolutely.
Okay, Abdul, what about this one? This is a 50-year-old female, and she has got insidious onset of neck pain. She had radiographs, and the radiographs were reported outside as normal, but she continued to have pain, so they organized an MRI, and these are the MRIs.
So this is sagittal T2 and T1 MRI with the axial MRI. I can see that there is a low signal in T1 and T2 in the C6.
Yeah.
Yeah, and okay,
So-
there is some compression in the spinal cord here, and
No, so we agree that there is a low signal in the vertebral body of 2, 3, 4, 5, C6. We agree. And corresponding, so whenever you look at the MRI, the key thing is to look at the T1, which you rightly did, because normally it has fat, and here there is low signal. So low signal, it's abnormal. And then what is happening on the axial?
I think there is extra vertebral extension, okay, and there is involvement of the around the vertebral artery.
Yeah.
I can see the cord is not bad. There is still
Yeah.
the fat around the cord. And
CSF.
yeah.
CSF around the cord.
CSF
And
around the fat. So this is like bony with soft tissue extension mass.
So in order to get the diagnosis or narrow the diagnosis, you have to consider two things. First thing is, we know that there is an abnormality in the vertebral body, but is there any destruction of the vertebral body or not? There is no gross destruction. There is mild loss of height, but there is no gross destruction. It's not destroyed, isn't it?
Yes, yeah.
You have a large soft tissue component around the vertebral body. Agreed?
Yes, yeah, I agree.
And then normally if you have certain types of tumor will displace the vertebral artery. If you have a tumor, the tumor can displace the vertebral artery or the tumor can encase it. In this case, it's encasing the vertebral artery, but the vertebral artery is patent.
Yeah.
So if it is a tumor, so there are certain types of tumors which will encase the vessels and won't compress it. Okay.
Yeah.
If the tumor is the tumor is very soft, especially lymphoma. Lymphoma can do that. Lymphoma is very, very soft. The lymphoma will spread around the vessels, but will never compress it. Unlike a normal tumor will compress and displace the vessels and the neurovascular bundle. In this case, you can see tumor in the vertebral body and the soft tissue, but it's encasing the vertebral artery without compressing it. So lymphoma is the most commonest tumor that will cause that. In young children, it will be Ewing's, but very, very rarely metastasis can do. And in this case, this is a breast metastasis with a large soft tissue component. Radiologically, your top diagnosis should be lymphoma because you have got large soft tissue component without compression of the vessels. It's encasing the vessels. So whenever you see this, what are you going to do next? So this patient was referred to you with neck pain, and this is what you have. So what are you going to do next?
So like we will continue the investigation for him. So we'll do MRI with gadolinium. We'll do CT scan, and we'll see the census score for him.
And the score shouldn't be bad in this case because the SIN score is not bad, isn't it? Because there is no compression, there's no posterior element involvement and all.
And then we'll look for do whole spine, look on other metastases. And,
absolutely.
So maybe better
the key feature is MR whole spine and staging, CT chest, abdomen, and pelvis. And because it's a female, you have to do the breast ultrasound or breast screening as well, because you have to ensure that there is no breast CA or anything. So you're right. So the key take-home message in this case is if you see a tumor and there's a large soft tissue component, think about lymphoma or metastasis. Okay?
Great.
Okay. 45-year-old with left arm pain and neck pain.
So this is a T2 weighted sagittal MRI and axial MRI cervical spine. I can see there is a 5-6, C6, C5, C6 could be also, disc prolapse with severe canal stenosis, the more on the left side. And actually, it's not clear. I cannot appreciate if there is a cord changes in the.
There are no cord changes because axial is always better. On the sagittal, sometimes because of the, if you can sometimes see an artifact. You have to always correlate with axial images.
So this is like C5, C6 disc prolapse.
Yeah.
Compressing left side C6 nerve root.
Yeah, yeah. So normally in radiology, there is nothing like a prolapse. So disc prolapse is a normal word that people use, but in the report, it should not be there because you can only have protrusion or extrusion, sequestration. So these are the key. So you can only have protrusion, extrusion. These are the most common. So this is a protrusion. I agree. And then you have to say whether it is central, paracentral, foraminal, or extraforaminal. In this case, so there is a large left paracentral disc protrusion. Yeah, we agree that it is compressing with impinging severe left neural foraminal narrowing at C6. So the other thing, whenever you look at a disc, is you have to see what is the signal. In this case, you can see on T2, it is very low signal. If it is low signal, it can be dehydrated disc or it can be calcified.
Sorry.
Isn't it?
Yeah.
So, and it's important because if you want to do a ACDF and if there's a large calcified disc, it's difficult. You might have to do a corpectomy to take it out.
Yeah.
So it's important. So if you see a disc which is low signal, it can be a dehydrated disc or it can be a calcified disc. So in these cases, sometimes you might have to do a focal CT to see if it is calcified or not. And as you rightly said, we have to assess if there is any changes in the cord. In this case, there was no changes in the cord. So this is a diagrammatic representation what we expect in the spine. The right side, this is how the normal vertebra and the nerve roots look like. And on the left, you can see nerve root impingement can be because of a disc protrusion, which can be posterior central, paracentral, foraminal. You can have an osteophyte in the neural foramen as well, which is causing compression. All right.
Abdul Jabbar, can I ask one question?
Yeah.
Yeah, just the previous slide at the same level, the prevertebral soft tissue.
Yeah.
Can you comment on this? Is this normal or?
There's a bit of fluid, but it's not increased. I agree. There's a bit of fluid, but there's no increase. So it's very non-specific.
Okay.
Yeah.
Thank you.
Okay. So this is a different patient. So Abdul, this is a different patient who has had surgery, and you can see he has had corpectomy and grafting. And in this case, you can see that there is high signal in the cord. Yeah?
Yeah.
Yeah. So this is what we call as myelomalacia. So this is gross myelomalacic change within the cord.
The
Agreed?
whole is white, huh?
Yeah, this whole, because the normal cord should be dark, isn't it?
Yeah.
So whenever you see a bright signal, that's what we call as myelomalacic change or high signal within the cord. So this is grossly abnormal. Agreed?
Yes.
Whenever you see high signal in the cord, it is not necessary that it is just myelomalacia. Okay. Before we go on to that, whenever you see changes in the cord, you have to see where are the changes on the axial. So this is a normal cord. You can have diffuse change in the cord. You can have focal fuzzy changes, or you can have a discrete focal. So this is one of the classifications for myelomalacia. But it's not very important unless you want to do research on myelomalacia. The key thing is to pick up the high signal within the cord. So let's look at a different patient. This is another patient, young 30-year-old, presented with neck pain. The canal is not too bad. And when you look at on the stir, you can see this high signal within the cord. Can you see that?
Yes.
And on the T2 also, you can see high signal. So what do you think about this one then? She presented with some neck pain, some pins and needles as well. So do you think this is myelomalacic change in the cord?
No, I think this is like, could like mass effect on the cord, maybe intradural, intral.
No. So let's look at it. I see what you're talking about, but roughly looking at the cord thickness, the cord thickness is not too bad, isn't it?
Yeah.
So if you take the white signal off, the cord is normal. We agree? And it's very fuzzy. So whenever you see abnormal T2 weighted high signal within the cord in a young patient and the canal is pretty good, you have to exclude multiple sclerosis,
Yeah.
MS.
Yeah.
And you can see further, there are small lesions higher up as well, next to the brainstem. Can you see these?
Yeah.
These are all not normal. So whenever you see high signal and the core and the canal is capacious, think about MS. What about this one? This is another person, T2 sagittal. Ignore the T2 sagittal, there is some high signal, but on the axial, you can see that there is some high signal in the cord in the posterior part. Yeah?
Yes, yeah.
So is this myelomalacia? There is no compression of the cord. So it's not myelomalacia. There is no disc. Agreed?
Yeah, I agree, yeah.
It is very symmetrical. So it can't be, it's unlikely to be MS. The location is very classic. This is vitamin B12 deficiency.
Wow.
So whenever you see a high signal in the cord, I showed you myelomalacia. I showed you a young person where the canal is normal. You have to think about MS. And I'm showing you another one where it's if it involves the posterior horn, posterior part of the cord, and it's very symmetrical, think about vitamin B12.
Okay.
Okay, good. Okay,
Doctor,
next
I have a
case.
question.
Yeah.
Sorry for disturbing. When you showed the first case of the syrinx post ACDF,
Yeah.
I think post corpectomy.
Corpectomy and
To
grafting.
me, yeah, for me, the picture is more of like a syrinx, like traumatic syrinx when you get it.
Yeah, I agree. That is but that looks like more a syrinx part, and the rest of it probably is cystic with myelomalacic change and probably evolving syrinx. I agree.
Okay.
So can we give a chance for Dr. Mahmoud Arbash to complete? Dr. Arbash, can you unmute yourself?
Yes, please.
Okay. This is a 20-year-old male with neck pain.
So this is a sagittal T1 and
Dr.
T2
Arbas?
images. Yes, hello?
Yeah.
Yeah, can you hear
What
me?
do you think? What can you see? Yeah. So what can you see? This is a 20-year-old with neck pain.
Yes. I can see this is on T1 and on T2, we can see that there's almost fusion of the C3, C4 body, which looks like there's revertebral soft tissue involvement. And there's high signal on T2. And this, on sagittal stair, also there's high signal with the involvement of the soft tissue, with the compression of mild compression of the spinal cord, but we have to check with the axial also.
There's no compression. There's no compression on the axial.
No compression?
No compression on the axial images. On the sagittal also, you can see that there is enough CSF. So there's no cord compression. Okay. Yeah.
And I can see that the soft tissue involvement extend down to C5, C6, C6, C7.
Yeah.
And also at the level of C6, C7, there's looks like also there's involvement of the disc space.
Yeah, this is just degenerative. This is probably a bit of degeneration or something. Ignore it.
Okay, so back to C3, C4.
Yeah.
It looks like there's involvement of the vertebral body.
Yeah. So what are you thinking?
I can think of infection.
Yeah. Absolutely. So whenever you see involvement of two vertebral bodies, and the key thing is to look at the end plates, you see that there is destruction of the end plates. So that is the key thing. If the end plate is destroyed, it is more likely to be bacterial spondylodiscitis, the classic standard. What is the most commonest organism?
In this case, maybe TB.
No. Normally, it is
for this one,
staph.
Staph aureus. Staph aureus.
Yeah. If the end plates are intact, if there is
then we think about
So if the end plates, so that's why whenever you look at involvement of two, next thing you have to look at is the end plates. In this case, end plates are destroyed, and there is soft tissue. So this is a normal standard bacterial spondylodiscitis. Absolutely right. Okay. What about this one? 70-year-old with neck pain.
So there's increase of this is sagittal T1 and T2 views of the cervical spine showing increase of the lordosis of the
Yep.
cervical spine with involvement. I can see there is a lesion involving the body of C2, C3, C4, and there's also on the T2.
T2, yeah. 2, 3, 4.
On T2, there is no. There is compression, I think, on this image of the spinal cord. There is no changes of the spinal cord by itself, but I can see that there is compression at the level of the C3, C4,
Yeah. Yeah. Means,
C4, C5.
yeah. Means I think it's indenting the cord compression.
Yes, indenting the cord.
You need to see the axial. So what are you thinking? So we agree that there are multiple lesions.
Maybe metastatic.
Yeah, so there's
Metastatic
multiple
lesion.
metastasis. So the key thing to note is that always whenever you look at metastasis, you can see here on T2, it is difficult to appreciate. These lesions are better to appreciate, but some of the lesions can be difficult to appreciate. On T1, it's quite easy. So always look at on T1 for metastasis, not T2. You can look at a stir. So this patient, if he's not known to have any tumor, he will need a workup. He will need MR of the whole spine, CT, chest, abdomen, and pelvis, and probably bone scan. Good.
Okay, thank you, Dr. Arbas. Can we go to Dr. Mu'taz? Mu'taz, can you go ahead? And Mu'taz, one of the grads of our fellowship here in Hamad. So,
okay, yeah, go for it. 65-year-old with left neck mass and pain.
Okay. So I can see T2 and T1 image.
We got T2 and stir. We got T2, stir, and an axial stir.
There is a heterogeneous mass, probably is involving the anterolateral part of the
T5. Yeah.
T5 maybe, anterolateral part of T5, and heterogeneous. I would say this is probably mass.
Okay. So I presume you're talking about this mass on the left side of the vertebral body of C5. So now, and you can see the same on the sagittal here.
Yeah.
T2 and stir. So tell me more about this mass. What is happening with the mass? So that is your vertebral body. So it's arising from the vertebral body.
Yeah, it's arising from, and I think there is also.
So what is this bright structure?
There is a rim enhancement, I think.
No, there is no contrast. We haven't given contrast. So we have got, there's no contrast in this. This is stir where, so that is your mass lesion, and you got something which is bright over it. You can see the mass lesion and it's bright over it. And the same here. So you got a lesion and there is bright signal over it.
Cartilage.
So, cartilage, absolutely. So what are you thinking?
So I'm thinking about osteochondroma.
Absolutely. So this is a large cervical osteochondroma causing nerve root impingement and all. But whenever you see an osteochondroma, what is the first thing that you have to see? What is the first thing you have to measure?
The cartilaginous cap.
Yeah. And what is your magic number?
2.
2. Absolutely. Perfect. So whenever you see an osteochondroma, cervical osteochondromas are not very common. They're very common in the long bones, but you can see cervical osteochondromas. And the most important thing is to identify malignant transformation. If the cartilage cap is more than 2 centimeters, it's more likely to be chondrosarcoma. Obviously, you also have to look at whether it is compressing the vertebral artery, the nerves, and the neurovascular bundle. All those are yes, but also malignant transformation. And this is another case where this is a large chondrosarcoma involving the posterior elements, and you can see the cartilage cap is so thick in this case. And if you want to read more about the, what about this one? This is another chondrosarcoma involving C2. And in this case, obviously I haven't shown you the axials. It's causing cord compression as well. And the key thing is to note that the signal, if it is bright on T2, if the tumor is bright on T2, your differential is chondrosarcoma and chordoma. In spine, lesions that are bright are chordoma and chondrosarcoma. In this case, all these are chondrosarcomas. And if you want to read more about chondrosarcomas, we published a paper in Journal of Clinical Orthopedics on osteochondromas of the cervical spine and a few chondrosarcomas as well and how they were managed. It was published last year. Good.
Perfect.
Right. What about this one? A 20-year-old male with neck pain.
Isam will take this question. Isam?
Yes, doctor.
Isam?
Yes.
Okay.
Hello?
Yeah. What can you see in this case? A 20-year-old with neck pain.
Right. We have
Concentrate.
to measure the diameter. I think this is osteoblastoma.
Osteoblastoma. Okay. So
Osteoblastoma or osteoblastoma.
Okay. Yeah. So basically what you see in the neck is whenever a young person comes with neck pain, you have to assess, for example, on stir, you can see osseous edema. The same here, there is a bit of soft tissue edema as well. Whenever you see non-specific, you can't identify a lesion. You always have to do a focal CT. And in this case, you can see a small osteoid osteoma. Osteoblastoma is a large osteoid osteoma. In this case, the nidus is about 5 or 6 millimeters. And whenever it is, then what we can do is we can put a needle and ablate it. So you're right. This is a case of osteoid osteoma. All right. What about this one, Isan? So this is a patient with 40-year-old with neck pain and left arm pain.
It's like intra.
So what can you see here?
Describe the X-ray, the MRI. Describe what you can see.
T2, T1 post contrast, T2 axial, and T1 post contrast axial. What can you see?
There's circumscribed high intense in T1.
This is T1.
Yes.
T1, you can't see it at all.
So it's high in T1 with contrast.
In T2, you can see high.
Yes.
And on
Low
T1,
high in T2 with enhancement with contrast.
But it's intensely enhancing. See, you can't see at all on T1. And on T1 post contrast, it just brightens like a light bulb, which means, isn't it?
Yes.
Okay. And you can see the same on the T2 axial. You can see it's a broad-based lesion on T2. And this is the T1 post contrast, which shows enhancement. So whenever you see a lesion, which is intensely enhancing post contrast, and if it is is it intradural or extradural?
Intradural.
Okay. So we know that it is intradural. If it is intradural, it's either intramedullary or extramedullary. Agreed?
Yes.
So it is most likely to be extramedullary, the way it appears. So
Yes.
whenever you see an intradural extramedullary lesion, which is enhancing, what is your differential?
Enhancement with infection.
No. See, the lesion is so, if it is infection, then you would expect so much soft tissue edema as well. You won't see just an edema just there. You will see a lot of soft tissue edema and enhancement all around it. In this case, around the lesion, everything is normal. The lesion is only enhancing. So whenever you see a lesion, intradural, extramedullary, your differential is meningioma and nerve sheath tumor.
Schwannoma.
Schwannoma or nerve sheath tumor. Yeah. So the way to differentiate it is in meningioma, you have a broad base. In this case, you can see it's got a broad base and a small tail. So if you have a broad base lesion, intensely enhancing intradural extramedullary, it is a meningioma.
Thank you, Isam. We'll go for Dr. Amle. Dr. Amle, one of the residents who are interested in spine. Amle,
Okay.
are you here?
Yes, doctor. Yeah, good evening.
Good evening.
Yes, doctor.
So this is a 20-year-old with neck pain. What can you see?
Okay, we can see we have a lateral radiograph of cervical spine with sagittal MRI cuts with alignment is maintained for this patient. Yes, with no significant cord compression.
Yeah. So this is T2. Sorry about the error. This is T2. This is not T1. Yeah, this is T2.
Okay, so in sagittal T2 image, I can see on the level of C4, I guess there is a high intensity.
Yeah. So that
Yeah,
means
there was
there is a bit of edema. So
yeah,
you can
C4
see that
body.
there's a bit of edema here. And that's T1. And this is a CT. So what do you think?
Okay.
So we can see a lesion involving the vertebral body.
Yes.
It is forming bone. So it's an osteoid forming lesion. It's a bone forming lesion in a young person, 20-year-old, and it is causing inflammatory change, which is nothing but perilesional edema. So bone forming lesion in a young person. What are the bone forming lesions?
Okay, osteoma can be, osteoblastoma can be as well.
Yeah, so in this case, the case that I showed you before, an osteoblastoma, in this case, itis is quite big. It's an osteoblastoma.
Yeah, osteoblastoma, yeah.
Yeah, so bone forming lesion, once you see the bone forming lesion, then you have to see the size. Is there any inflammatory change? If there is inflammatory change, then it's either an osteoblastoma or osteoblastoma. Okay?
Okay, thank you.
All right. A 30-year-old, who is it? 30-year-old male with left neck pain. Abdul?
I can take this, yeah. So this is a lateral cervical spine, and the only abnormality, and I can appreciate that there is a C23 anterior ossifieds, and there is
yeah,
5, 6.
Yeah, ignore that.
Ignore this.
Yeah, so vertebral body heights are normal. Alignment is okay, is normal. Disc spaces are normal. Anterior soft tissue is normal. You draw the lines, draw a line along the odontoid. Anterior spinal line is normal. Your spinolaminar line is normal. What about the posterior vertebral body line? That's normal. But you can see this extra structure here. Can you see this?
Yeah. There is like we have to do advanced images to OPLL.
OPLL.
Absolutely. So you can see increased density in the posterior elements. And if you do MRI on this case, what you can see is you can see thickening of the posterior longitudinal ligament. And if you do a CT, in this case, you can see its ossification of the posterior longitudinal ligament. And obviously there's a classification. I won't go into the classification of OPLL, but whether it is segmental, whether it is focal, or whether it is mixed pattern. But in this case, obviously it is causing cord compression. So one of the things that you have to see on cervical spine is OPLL okay, good. When you compare that with this, what about this one? So this is opposite to that. What can you see this one? What can you see?
Can I take this?
Yeah, okay, please. Who can? Yeah, I saw.
So I think this is this. There is anterior anterior application of the ALL or there's calcification and continuity of the disc space, obliteration of the disc space between C3 and C4.
Yeah, absolutely. So this is DISH. This is nothing but diffuse idiopathic skeletal hyperostosis. So, but there is also what we call as a FISH. You also have to remember for what we call as FISH, which is the same but focal. So the key thing is to note that the disc spaces are more or less preserved except in this region. And unlike OPLL, here is the anterior aspect. So this is a DISH. So this is an easy case. All right. Okay, Abdul, what about this one? A 20-year-old male with neck pain again. All of these patients have neck pain.
So this is a lateral X-ray. Look like normal lateral X-ray of cervical spine. This is CT axial. I can see.
No. On the radiographs, on the axial, what about on the lateral radiograph?
Yeah,
what about this?
Yeah.
That is not normal. Posterior elements of C2. Can you see?
Yes, yeah. I can now appreciate it, yeah.
Yeah, it's because that is the normal vertebral body. You can see some extra osseous component, extra bone or more density overlying the posterior elements of C2. Okay, so you did a CT and these are focal CT cuts, axial CT cuts. So what can you see?
I can see like bony enlargement or ossification of the posterior arch of the C2.
Yeah.
Yeah, and it's like sunrise.
Absolutely.
Sunrise.
Yeah.
Osteosarcoma.
No. So basically, one of the things in radiology is if it is an unusual site, you take it and put it in the normal site. So normally bone tumors are more common in the distal femur and proximal tibia. So if you take this and put it in the distal femur, you would say speculated periosteal reaction, 20-year-old. You have to think about osteosarcoma or Ewing sarcoma. So it is just because it's an unusual site, you're thinking twice. So whenever you have an abnormal lesion, sometimes you have to take it out and put it in a normal place, distal femur, proximal tibia, and you have to get a diagnosis. So here, differential was between osteo and Ewing's. On radiology, it looked like osteo. On biopsy, it turned out to be Ewing's. But that is a moot point. The main thing is to identify that this is a malignant bone tumor, and it has to be referred to the tumor center.
Okay.
Okay. All right.
So we'll go Mu'taz again. Mu'taz, interested to take this? Hello? Isam, Mu'taz?
I'm here.
Okay.
I think this one is difficult.
50-year-old with neck pain. So it's not difficult. It's very easy. So this is a T2 image. This is a T1 axial and T2 axial. Remember on T2, fluid is bright. So this is the brain stem and that is your cord. On T1, fluid is dark. So here we can see on the parasagittal image, this is not the midline. On the parasagittal image, we can see a lump. You can see abnormal mass. Agreed?
Yes.
And on the axial image, it is here.
On the left side.
On the left side. Now let's look at the feature. It is a bit low on T1 and it is bright on T2. So it's got something like liquidy, like thick liquid, like a synovial cyst, like a ganglion. And it's arising from the joint. It is arising from the articulation between the occipital condyles and C1. So this is a large synovial cyst or a ganglion. Okay. So nothing is difficult. You just stick to your basics and then you will crack the diagnosis. So this is a large synovial cyst or a ganglion arising from the articulation between C1 and occipital condyle. Okay?
Yes.
So if you want to read more about synovial cysts in the cervical spine, synovial cysts or facet joint cysts are very common in the lumbar spine. In the cervical spine, they're not very common. But we published a paper on MRI imaging of cervical spine, intraspinal extradural synovial cyst in the Canadian Journal of Radiology. So on this, you can see several examples of these. Okay?
Yes.
All right. Abdul, I think you should take this one.
Yes. This is T1 and T2, sagittal T2 of the thoracic spine.
Yeah.
Assume it's mid-thoracic. And there is a distraction lesion of, I think, T6 or some.
Yeah, T6.
Yeah, and there is it's low in T2 and it's low in T1. And there is some extension to the disc. The disc below is preserved, the disc above is not.
And it's invading the vertebra above.
Yeah.
Okay, so now, we know that there's a tumor. So the key thing here is to note the signal of the tumor. So the tumor here is low on T1, low on T2.
Yeah.
Most of the tumors are either intermediate or bright on T2 or stir. You can see on stir, it's low.
Yeah.
So whenever you see a tumor which is low on almost all sequences, T1, T2, stir, you either have to, that means it contains fibrous.
Okay.
Or it contains giant cell tumors. Yeah. So if the lesion is low on T1, T2, you have to think it's either fibrous or it contains giant cells, giant cell tumors or something. Okay. So GCT is a nice diagnosis, but GCT is very unusual to go across the disc and go into the other vertebral body. So the diagnosis is not the problem, because to get the diagnosis, you have to do a biopsy for this one. We agree. As long as you have a systematic approach of coming to the differential diagnosis, that's fine. So because the lesion is low on T1, T2, your top differential would be giant cell reparative granuloma. And then you have to look at the bloods as well. In this case, the serum cholesterol and there was hyperlipidemia and there was high cholesterol levels. Biopsy showed giant cells, but the giant cell tumor markers was negative. So we made the diagnosis of xanthoma of the thoracic spine. Don't worry about the final diagnosis. Most important thing is the approach. The only way we could make the diagnosis of xanthoma was because we had the serum lipids and the serum cholesterol, which was high. And on the histology, there were giant cells and there were cholesterol clefts. So it's for histological diagnosis.
So again to Dr. Ishaq, please. Dr. Ishaq.
Okay. I know we are talking about neck pain. This is about the thoracic spine. So if we got T2 sagittal, we have got axials. This is the axial from the top level. This is the middle level, and this is the lower level. So what can we see?
Okay, so we have a sagittal T2 MRI involving cervical and thoracic spine.
Okay, let's get the sagittal T2 first. Yeah, just talk about the sagittal T2 first.
Yeah, sagittal T2, we have good alignment of the cervical and thoracic with little loss of lordosis in the cervical spine.
Yeah.
And we have at the level of 2, 3, 4, 5, I think 4, 5, we have stenosis. And we have multi-level high signal intensity.
Ignore them.
Yeah.
Ignore them. Just concentrate on the cord.
Okay. So the cord in the level of the mid-thoracic level, I think there is some a change in the signal. We have thickening and change in the posterior aspect of the cord signal.
And what about the contour? Is the cord going straight or is it?
No, it's like it's pushed anterior and compressed against the thoracic bodies.
Yeah. So basically, what I'm trying to show is the cord here is pushed anteriorly. So this axial, you can see on the top, this is the normal cord. And at the level where it's pushed anteriorly, you can see the cord is pushed anteriorly. And distally, it's normal again. The signal within the cord itself here is normal. There's a bit of high signal here, ignore that. But there's here itself, the signal is normal. Just to give you an example, just these signal changes that you're talking about on the corner, these are corner inflammatory lesions. So patient has underlying spondyloarthropathy. So ignore that for the time being. So let's look at the cord itself. So why is the cord pushed anteriorly at that level?
Yeah, so we have a mass occupying lesion that involves the posterior aspect of the canal.
But on the MRI, there is no abnormal mass signal. You can see there is no mass here. This is just CSF flow. Can you see?
Oh, okay.
Can I comment?
Yeah.
I will not say the diagnosis, but I just want to say one sign. Is this scalpel sign?
Yeah.
Okay.
Scalpel sign.
Again to his Ishaq then.
So what's the scalpel sign? Do you know what the diagnosis is?
Cord herniation, no? Herniation of the cord.
Absolutely. So this is idiopathic spinal cord herniation. So normally it happens at the level of T4, T5. And what happens is the cord, there's a small defect in the ventral dura and the cord goes out and comes back in. And so this is classic. It happens at the level of T4, T5. So this is a case of idiopathic spinal cord herniation. Obviously, there are, as I said, there are corner inflammatory lesions in this patient because of spondyloarthropathy. And obviously, if you want to read more about idiopathic spinal cord herniation, I wrote a paper way back in 2012 on this.
Nice.
Okay. Abdul, this one is for you.
Okay. Okay, this is like a sagittal T2 of the upper upper cervical. I can see that there is a destruction mass of the C2, okay, which is compressing the cord, And
so let's go back. So there is lack of ossification or normal fusion of the odontoid. So that's a congenital abnormality.
yeah.
Okay. So we can see something involving
the
the posterior
proximal
part
migration, proximal migration of the C2 on the cranial.
No, like osodontoidium, like failure of fusion of odontoid.
Okay.
So because of that, you can see part of the odontoid that it hasn't fused. But the key thing to note is that you see all this low signal at the back. Yeah?
Yeah.
And on the T1, again, you can see this all low signal. And
So
then, and on the axial, you can see all the low signal at the back. Can you see that?
Okay. I think there is continuity of the, with the brain, I think. Or...
No, so this one is just, I did not take a proper sagittal. On the next image, the cord is normal. This image, the cord looks abnormal. But actually, when you look at the whole series, the cord is normal. The key thing is to note that is all this is abnormal. This posterior low signal lesion. So, and on the axial T2 medic also, you can see this is all low signal. And when you do CT, you can appreciate that there is lack of fusion of the odontoid. But at the articulation of C1, C2, you can see that soft tissue and you can see all this small.
Yeah.
So what do you think it is?
Is it this is osteochondroma?
Chondrosarcoma?
No. So if you take this and put it in the knee joint, what will you get?
Enchondroma?
PVNS?
No, PVNS.
No, you see is multiple loose bodies. Multiple
synovial
osteochondromatosis. Absolutely. It's just because it is in the articulation of C1, C2, you're thinking twice. If you put this in the knee, your diagnosis will be synovial osteochondromatosis. So you can see it very rarely in the cervical spine too. As long as you stick to your basics and you do follow the steps, it's low on T1, low on T2, and low on T2 axial. And hence you have to think either of calcification or fibrous. You do a CT and you can see multiple loose bodies, synovial osteochondromatosis involving the articulation of C1, C2. Yeah?
Yeah.
Okay. So this one, I will go through this one. So this is the T2 sagittal. The axial images are not the best, but what we can see is a small cyst involving the left lateral recess. You don't have a lateral recess in the cervical spine. So it is this, but the images are not the best. But a small cyst in relation to the facet, this is a facet joint synovial cyst of the cervical spine. As I showed before, of the upper cervical spine, in this case, it's of the mid/lower cervical spine. Yeah?
Yes, yeah.
All right. Who wants to take this one? The last two cases.
Dr. Ishaq will take.
Yeah.
Okay.
Yes, this is a lateral radiograph of cervical spine and sagittal images T1 and T2 MRI.
Yeah.
Okay. X-ray is showing severe degenerative changes with involving the upper cervical level, C3-4 and C4-5.
Yeah.
On MRI, we can appreciate
No.
that.
Let's finish. What about the radiographs? Everything done? So we have seen that there's degenerative change. What about the atlantoaxial?
Wallahi, it's not very clear because it's very small. Okay.
So you can see that the predental space is increased.
Yeah.
The ADI is more.
ADI, yes.
Yeah. So on the radiographs, we know that there is degenerative change, more marked at C3-4, a bit here, but the predental space is normal.
Muhammad, look for the tip of the odontoid.
Yeah. Where is the tip of the odontoid? So look at on the sagittal now.
Yeah.
It went inside the.
There is
what do you call that?
Invagination.
Yeah.
Occipital invagination.
So basilar invagination, because normally you expect the odontoid should be outside. You draw a line along the tip of the clivus and the posterior part of the occipital occipit here. Normally the tip of the odontoid should be inferior to it. In this case, it's gone cranially. So this is a case of basilar invagination.
Mhm.
Yeah, and it's important to identify it because this might be the cause of the neck pain. And normally whenever you see basilar invagination, it is because of inherent weakness of the bone. So you have to exclude in patients with rheumatoid arthritis, osteoporosis, or any hyperparathyroidism, you can see this. Or even in osteogenesis imperfecta. And the last case,
Isam,
Isam.
for Isam, he's nagging to take it. Okay, Isam.
Okay. Last case.
ماشي يا أستاذ. Sorry. So this is a lateral radiograph of the cervical spine. They're showing increase in density of the C2 body.
Okay, increased density of C2 body and what else? So let's look at C2. So it's involving the peg. The
Yes.
body. What about the posterior elements?
There's.
Is that normal?
No, it's not normal. Also, there is increase in density, but it's like ill-defined.
So the whole of C2, the
Ill-defined.
body, the posterior elements, most of the posterior elements are dense. First thing, and then look at the width of the posterior elements of.
It's more than the.
When compared to C3, is it more?
Yes, more. Yeah, the facet.
So we have got the bone is expanded.
Yes.
The bone is more dense.
Bone forming. Bone forming lesion.
No. The whole bone is expanded. The whole bone is dense.
Osteopetrosis?
Osteopetrosis is normally diffuse. You will never see a focal osteopetrosis. Osteopetrosis means the whole spine will be normal. So take it out and put it in the pelvis, put it in the femur, put it anywhere else. So the whole of the iliac bone, if it is expanded,
Paget?
sorry, Pagets. So this is Pagets. Absolutely right. So the take-home message is if you see expansion, the whole vertebral body is involved. If there is coursing of trabeculae and all, you can do a CT. And then if you see coursing of trabeculae, you know that it's a Pagets. So sometimes you can see atypical lesions in normal lesions in atypical location. The only way to diagnose this is you think about it, what it is, and put it in a normal place, and then you will come to your diagnosis. I know you are spinal surgeons, but if you want to know more about our webinars, the next webinar is on tumors and foot, and we'll be talking about cartilage tumors and the foot.
Thank you very much. Thank you very much.
Thank you, Rajesh. Thank you very much. Very kind of you. Great. Good session.
I hope it was useful.
We need to get our trainees how to go through this SIB and speak, practice.
No. I hope you like these cases. I just wanted to put a spectrum of cases.
Very good. We need to do few more sessions like that.
Yeah.
And we will try to do one with general orthopedic trainees as well.
Yeah, anytime.
Yes.
We are happy to help.
Yeah. So we do general orthopedic trainees. We do usually on Thursdays mornings. So which would be probably 9 o'clock your time in the morning Thursday, if that may be possible. But we will be flexible. We'll see.
No, that's fine.
Thank you
I hope
very
you
much.
liked it. Thank you.
Thank you very much, Doctor. Thank you very much.
Thank you very much.
Have a good day, Rajesh. And say hi to
you can send us some feedback. If you can send me some feedback, that would be great.
Absolutely. And send hi to Mal Granger.
I will.
Thank you.
Thank you.